first of all, I have to say that this work is done in collaboration with Laura Brown and also at UCL, and also the second part with Ronald Kananura at the LSC. Also, as Hill said, my main interest is around women's health throughout the life course. And I see menarche basically as one of the tassels of the interest I've got throughout the life course. So one of my main focus is to understand the impact that reproductive lives histories in low and middle income countries have on aging and health later on in life. So I see basically menarche as the beginning of this. I'm also interested in menopause as well, because I'm interested in the bookends. So basically this is one of the key points. And I start everything by doing a review usually of the evidence out there, and also a review of the data. So what I'll present now is basically the combined work of a paper that has already been published on microdata. It's been published in the B&J Global Health last year, and also very ongoing work. So ongoing that I was actually running models up until 10 minutes before of this presentation on more macro data. So why do I think that menarche is an important indicator, and why do I think that menarche is important to study, mainly in terms of timing? First of all, I'm giving it for granted here that everyone knows what menarche is, but I shouldn't do. Menarche is the timing of the first menstruation, is the first period. You might think that this is something that is well known and researched, but the more I looked into it, the more gaps I could actually find in the literature. It is important, and we mainly rely on literature in high-income countries, because puberty is a period of increased vulnerability, whether it's early or delayed. If it's delayed, usually it could create stigma, mainly in settings where fertility is highly valued. It's almost like an acknowledgement of being a woman, of fulfilling a kind of task in life. An early onset, on the other hand, could give a sense of promiscuity, could be seen as a danger for families. We've seen, for example, that in settings of conflict, a student of mine looked at Iraq. Often women during a setting, during conflict, were married earlier, just because of the fear that they might be raped or they might not be secure. So early puberty could actually instill a sense of insecurity in both the woman and the family surrounding her. It's often the case, for example, in India, that we see that girls are not allowed in certain settings, and there is a higher rate of school dropout as well, because sanitary pads are not affordable, or because simply there is a stigma or stories around what the actual period could do. So, for example, in many settings, women are not allowed in temple during menstruation. So an early onset of menarche, of the menstrual period, could actually have serious implications at social and also mental health level. There are also some signs, and here I refer to a paper that was published about 10 years ago, where there has been suggestions that age and menarche could serve as an indication of socioeconomic inequalities, wealth and residence. But overall, menarche is mainly being studied from the clinical point of view, and not as much from a social science point of view. So that kind of approach is missing. What do we know at micro level? There is wide evidence, mainly from high-income countries, that age and menarche is decreasing. This is due to improvements in nutrition and overall health outcomes. So usually the level of nutrition is probably the best indicator. I mean, age and menarche is also genetic, but also we have then that throughout evolution and generational changes, age and menarche declines. The decline in age and menarche, in terms of the consequences of this, has been seen to have an impact on the uptake of alcohol and other substances, decline in the age of sexual initiation, and also early school dropout. again, so far the knowledge is mainly from high-income countries, as in low and middle-income countries, we lack the data. What do we know at macro level? At macro level, again, there is a scanty evidence of how age and menarche is linked to socioeconomic indicators, as well as to the epidemiological and transitional nutrition. There is a paper that was published in 2019, and this is basically most of what we go with. The evidence there shows that there is a clear link of menarche with the demographic transition, but it kind of stopped there. And the main issue with the data that have been used so far is that they rely on old aggregates. I mean, the SAFA paper relies on published data, and they don't really rely on time trends and on consistent and comparable information. So, for example, the SAFA paper, and I apologize to the author if I'm butchering the name, but I think it's pronounced like that, shows this really nice map. It was a lot of work to actually put all these data together. But when you actually go into the footnotes and the appendices, you realize that for most of these countries, the data are decades old. There isn't really a time trend there. And so the macro analysis is not really relying on a time series, is relying on kind of unstructured data across time. I still think that is really interesting, the results that they got. They didn't get as much on the socioeconomic development, but there was a clear link to adult female mortality and fertility rates, possibly as a proxy of the overall quality of the environment, also in terms of the services, health services that were offered, and also in terms of the family planning offered access in that period. So my research focus basically was to try, and it started as a kind of scoping exercise, where I wanted to know what data were available, because I was really interested in menarche as one of the indicators that leads to health later on in life. So I wanted to see what databases can I use, what data, and what's the evidence out there. But then I got really interested in, as you do, you kind of go off a tangent, in the linkages between socioeconomic indicators, both at micro and at macro level. And mainly this is more the second part, and this is the part that I'm working more at the moment. I wanted to see how menarche follows more of an epidemiological, nutritional, and demographic transition. Most of you being linked to CPC will know that the demographic transition goes hand in hand with the epidemiological transition. But it's quite interesting how the epidemiological transition then goes with the nutritional transition, which is improvements in health outcome linked to an improvement in nutritional intake. But I think what's really interesting there is going to be to see how the nutritional transition in low-income countries is going to link up to what we're seeing as well at socioeconomic level differential with high-income countries, where we are seeing for a kind of two-speed population with, on one hand, the better nutritional attainment with higher wealth levels, but then the worsening of the nutrition with a double burden of malnutrition, where you have the concurrent obesity and stunting at the same level because of the malnutrition that is due to overnutrition. I'll probably put too much there, but I'm happy to develop this later on, which I think actually I'm going to link up at the end, which is probably one of the things that is driving me in first looking at this in a descriptive way, but then I think we need to kind of engage more deeply into the more theoretical aspects of the nutrition transition. So as I said, I start with a scoping into this, and I wanted to see what was out there in terms of the the papers that looked at menarche timing in low and middle income countries. Well, there wasn't much out there, and mainly descriptive. But what was more interesting was actually how many of them used the demographic analysis survey data. And I was shocked that out of 2,000, only 10 actually used the demographic analysis survey data. And for those of you who work in low and middle income countries, you know that that's probably the go-to data when you want to analyze anything related to reproductive histories. There isn't really anything that is more comparable or more useful and direct and straightforward to use than the DHS. So then at the same time, I was actually looking at the data. And again, the situation actually looked even more depressing, because you would think that a question where you just ask, at what age did you have your first period, would be pretty simple and straightforward. But actually, even in the DHS, where this question would be easy and simple and straightforward, I found out in the end that only 16 of the World Fertility Survey, and trust me, it was a lot of fun to actually use the World Fertility Survey, which was the pre-DHS, and 28 demographic analysis surveys from only 27 countries actually included that question. Also, there were only 5 countries that had repeated measures. Countries like Botswana only asked the question in, I think, 1992 or something like that. Even India, only in 2 of the national fertility health surveys. But the good thing was that the period spans from 1986 and 2017 in the Philippines, which meant that I could actually reconstruct quite a bit of information, which was actually reconstructing pseudo-cohort data, because I could go by cohort for the analysis. So I reconstructed a period that went between 1940 and 2000. So quite a big span, which related to the demographic and the epidemiological transition in many of those countries. At macro level, we put together World Bank, UN Population Division, key socioeconomic indicators, and actually even the FAO, and imputed them for missingness. These measures were set at the time of birth to account for the impact that these kind of indicators had throughout the life course, so that they were matched by cohort, not at the time of the data collection. In terms of methods, at micro level, I simply used a register regression where I wanted to know what was the likelihood of having an early onset of menarche, which was set according to the literature to below 13. And at macro level, first of all, we matched the, we filled the gaps in the data set by using predictive mean matching by country grouping and using according to the variable a priori information. And with this, we basically reconstructed a period between 1960 and 2020, where we could actually reconstruct the whole generations. We started in 1960 because there were too many data points missing before 1960, so we looked at a later period. The modeling, we approached it from 3 different perspectives and then compared it according to the goodness of fit. So we looked at OLS with fixed effects at year level, then mixed effects and with a country group as a random intercept, and then mixed effects with the country group as random intercept and time as slope. So in terms of what we got, yes, I know there is a lot of noise there, and I'm not going to go into the details. If you're interested more in the kind of trends, you can look at the paper as well. But I think it's clear that overall there is a declining trend, and this is much more clear after the 1960s. The noise is mainly into the previous couple of decades. So the convergence here into the second period is much clearer. So we definitely see a generalized link. What I want to stress about on those results at at individual level is more about the socioeconomic differentials. So there are two messages basically coming out of the individual level data. First of all is that the picture depends very much from the country. Actually, there are three messages. One is that it depends very much on the country. The second one is that education more than wealth. Wealth here is calculated with a standard indicator of which is called the asset index indicator, which is calculated separately for rural and urban areas. Is basically the most recognized way to measure wealth in using survey data. So education level was much more significant and more kind of consistent throughout the countries than wealth. So that was another interesting. Thirdly, where wealth is significant. Here I'm giving you just two examples. These are two examples of countries with trend data. So I could actually see a difference in across time. It's really interesting that the older cohorts, they have a different trend according to wealth. The younger cohorts, they definitely go with the gradient of wealth. So the younger cohorts, you definitely see that the wealthier, the more likely to have an early menarche. Instead, in the past, we got a different trend, so showing that there is a generational, a cohort difference going on there. And we find it both for the Philippines and Indonesia. The same result is not actually in the education, where there is consistently a gradient going with the direction that we expect. So that the wealthier, the more educated, basically they have a lower menarche. To remind you, the evidence usually is that better nutrition, better access to health services usually leads to a lower age and menarche. So that was the most interesting part of the micro data analysis. At macro level, the way they approached it was from a framework, basically, that trying to understand the factors and how they might work in relation to age and menarche. So when I had to choose the variables, I relied pretty much on the literature as well, and I also relied on the SAFA paper and what they did. There are quite a few differences, though, on top of using completely different data. So I've looked at the level of literacy, so the percentage of literacy, the human capital index, which I have to admit with you I wasn't familiar with, which is a World Bank indicator, which is based also on measures of health as well as education, GDP, percentage of rural population, food production, and calories intake. So these have been used in the SAFA paper as well to just show a general level of production at country level in terms of linking it to the to other factors. It's really difficult. I mean, I've put these in 3 boxes, but you can't imagine how many times I've moved one thing from one place to the other. But one of these days I'm going to settle, and there is a lot of intersection anyway, because it's quite difficult to choose how food production is in the green box rather than the epidemiological box. The socio-demographic development, this is also, I mean, these measures are both to test and also to confirm some of the results seen in the past. So percentage of teenage pregnancies, total fertility rate, mean age of marriage, age of first intercourse, life expectancy, under 5 mortality and maternal mortality ratio. From an epidemiological perspective, percentage of child overweight, child wasting, child stunting. So wasting, to remember, is children that are too thin for their height. Child stunting is children who are too short for their height. So that's more in terms of one is more undernutrition, the other one is malnutrition. Percentage of anemia in children, sorry, I should have specified there. Calories consumption, female body mass index and overall population obesity. So a mixture of both child and adult. As I said, the measures are applied to the child cohort. So when I say female body mass index, that refers to an older generation, probably the parents' generation. The same for calories consumption and obesity. So actually that should probably split into two. And let's start with the old kind of correlations. These are probably the most interesting results. And they go in the direction that I was expecting them to go. And I sound surprised because I didn't expect so much to be going in such a direction. So the ones that you would expect, that where there is a kind of more towards the end of the epidemiological transition, also to show or demographic transition, like population obesity, it's a negative correlation. Human Development Index and GDP, it's a negative correlation, as well as food production. On the other side, the ones who are positively correlated are, for example, the total fertility rate or teenage pregnancy, which is interesting because it shows that it's not true that earlier menarche leads to an increase of teenage pregnancy. The other one is interesting is the maternal mortality ratio, which is probably one of the best indicators for health system functioning and also in terms of health development. Also percentage of rural population, again, this is linked to a kind of transition, and also child mortality. What is really interesting though is that severe stunting is not really significantly correlated, as well as wasted, actually, which I haven't put there. So there is much more of a correlation with overweight rather than with malnutrition. Looking at the models, and I'm just showing you one of the models. So first of all, there isn't much of an improvement between the three types of models that I'm testing. So I'm just showing you here the kind of mid-level, mainly because there wasn't really the slope at year level wasn't significant. So the mixed effects at country level, if I also tested at both a country level and a year level, and it wasn't significant. Well, first of all, the economic development doesn't seem to be there as much anymore. If you look at the coefficients, or if you look at the significance, it seems that it kind of goes into insignificance, what you would consider as economic development. The demographic one instead is probably one of the most interesting one, because the relationship remains as we have seen it before. Although the child under 5 mortality, teenage pregnancy, and the MMR, their coefficients actually, they don't show much of a difference there. Where we have more of a difference is in the more epidemiological factors. Interestingly, female BMI, and this is something that, if I have to go back to my initial one, I think really and truly what's interesting coming out of this, but also of the literature, is trying to understand the trends in the nutritional transition and what is actually happening in low and middle income countries. So there is definitely a need to investigate further why you have the female BMI is a positive relationship, well, is negative on the population obesity, and then is negative on the children overweight, while the underweight and wasting is actually not significant. But there is definitely a correlation with children overweight, so that relates to the same population. But I'm not quite sure at this stage why female BMI is actually having a positive relation there. So, do I consider, to answer my first question, menarche as a global health indicator? Well, I think it's heading in that direction. I think there is definitely something interesting going on, but there are still lots of questions. And I think at the end of this, I think I've got more questions than answers. Still, notwithstanding that, I think that there are lots of interesting results there, which lead into more research. So overweight trends, they seem to be more important than underweight. There seems to definitely be a reflection on menarche, which is much more into the improvement of nutrition rather than on the bad nutrition, but we need more information at country level. Human capital more important than economic capital, and there are some signs of overall linked to development, but is it because we are basically using other proxies, and is it because it's really and truly is the health of individuals that makes the difference within development? And the main linkages are, in my opinion, more decisive to the demographic transition as expected, so it kind of confirms what was said in a previous paper. I think we need more analysis on this. The DHS has finally committed to include, I don't know whether to shut me up as well, or whether they were just doing it out of their own volition. And they have committed into including a last age and menarche in all their data sets from the last round. I found it interesting when I was looking for data and talking to people, like, for example, people that work in in-depth, which is demographic surveillance systems in a lot of Sub-Saharan African countries, when they said, oh yeah, we never thought about it. Why don't we collect that information? It could be so easy, and it does have so many, it does lead to so many other things in health. So there is a need to include it more widely into health service. At the same time, I still don't understand why menopause is not included in aging service. But anyway, but I think that this study actually, and the previous one that we did, I think if anything, it strengthens the idea that we need to include this variable. And my hope is that through the analysis of pseudo cohorts, reconstructing the cohorts, but also through the analysis of further rounds of the DHS, as well as longitudinal data, even if we were to collect the last wave of a longitudinal survey, like, for example, the young lives, the one that is collected in Peru, India, Ghana, and Vietnam, we could actually just reconstruct retrospectively. So it's never too late to include it even in ongoing longitudinal data sets. I think that it should be included even in aging data sets, but anyway, that's probably pushing it a bit too much. So I think these are my conclusions, and I look forward to your thoughts and comments. Thanks.